Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Shehryar, currently working as a resident virology. Today, the topic of presentation is Crimean-Congo hemorrhagic fever. Starting from case history, a 16-year-old male from a farming family who had contact with the cattle presented a 5-day history of fever, headache, abdominal pain, 2 episodes of vomiting, and gingival bleedings. So, laboratory investigation revealed thrombocytopenia, Crimean-Congo hemorrhagic fever virus RNA was detected in his blood sample by PCR. He was hospitalized and treated symptomatically. After a few days, he showed improvement clinically. His platelet TLC returned to normal. This is the PCR report of that specific patient. Okay. So, about the virus, it's a widespread disease caused by the RNA virus of the genus Nairovirus of the Virinaviiridae family. It's a tick-borne virus. Only 3 members of this family cause human disease. That is the Dogbe virus, Nairobi sheep disease virus, and Crimean-Congo hemorrhagic fever. So, knowing about the history, the virus was initially detected in 1940s when the Soviet troops and local civilian and Crimea experienced a severe hemorrhagic illness during World War II. At that time, it was named as Crimea-Hemorrhagic fever. Later on, decades later, during 1960s, a similar virus was identified in Democratic Republic of Congo in a child. The two viruses were found to share antigenic properties, leading to their classification as the unified name Crimean-Congo hemorrhagic fever. Here we can see on the map, generally it is mostly prevalent in the area of the African region, different like the Congo, South African region, like Madagascar and other region. Regarding Central Asian region, that is Russia, Tajikistan, Turkmenistan, Pakistan and Afghanistan, it is located. In Europe, it is also prevalent in Turkey, Greece, Spain, etc. So here we can also see on this map like the different cases that was detected during different time period, like in Turkey from 2012 to 2015, 9,787 cases were detected and the case fatality was 4.8%. While in case of Pakistan, 252 cases were detected in that time, case fatality was 13.9%. It's from 2019 to 2024. Okay. So this is taken from our honorable supervisor, Professor Wahiduzzaman Tariq. These slides are taken from his presentation, although we all know that he has done tremendous job regarding this virus, specifically in Pakistan and abroad too. So at that time, there was chaos in different communities about this because the fatality of the virus, the mortality was too high. So he addressed different communities, different hospital, public health sector regarding the virus, its prevention, its treatment. So this is why it is aided. Okay. So this is one of the outbreak in which he generally treated different patient. Here is about Afghan refugee in which he expired, and there was also a history of a nurse who get this disease from their specific person. So he addressed all these cases at that time very well. This is one of the patient picture taken from his presentation of the isolation ward at that time, which was built. So, okay, so this is the article which was published by our respectable supervisor at that time in Park Tribune about, because there was different myths in the community about whether if the infected cattle meat can be consumed or not. So he addressed at that time that like with proper cooking, yes, the virus can be properly eliminated and it can be used. Okay, so generally this is a tick-borne virus, as in we all know that Pak-Afghan border. So because of the communities, because of the different tribe, with along with their cattle, when they cross these borders. So this is one of the reason that it's highly prevalent in area of like KP, Quetta, etc. Generally, other viruses of this group is also very important, like some of the viruses which is named after some of the region of Pakistan, like Hazara virus and Dera Ghazi Khan, because these were isolated first, detected first in these specific areas. But these generally mostly cause diseases. It's related to cattle, non such pathogenic to humans. Talking about reservoir, a wide range of domestic and wild animal make its reservoir. Viral reservoir are domestic animal, sheep, goat, pigs, etc. Animal get the virus from the bite of infected ticks. Many birds are resistant to the infection. About the vector, it is a hard tick exodate of the Haloma genus. Larva and nymph tend to feed on rodent, hare, and ground dwelling birds. Here we can see the picture of the Haloma tick because it is the main vector of this virus. Okay, knowing about the tick cycle. So generally, the gravid female, the tick, that's Hyaloma tick, when it give eggs, mostly in the spring season, when these egg hatch, it a larva which is six form, sorry, six leg larva, mostly in the late spring, come out from these eggs. Later on, this larva, for the feeding purposes, attach itself to rodent like hares, rabbit, just for feeding purposes. And at that time, the first molting, like it's take off its first cover. By the summer, this larva then change into next stage, which is nymph. Nymph is 8 legs, while the larva is a stage with a 6 leg. It is much more mature than larva. Then into adult, again hylomatic, which can again infect and can attach itself to the animal. About transmission, generally primary human transmission, 80 to 90% of the human are infected through tick bite or direct contact with the blood of infected ticks. Secondary human infection transmission occur through direct contact with the body secretions, organ or other body fluid of infected persons. High transmission risk when providing direct contact care of the handling dead bodies. In case of like burial, so for that purpose there is a proper protocol for safe burials. Okay, so who is most vulnerable? Because it is related to tick, and tick is related to cattle. So generally farmer, livestock worker, they're at high risk because of the tick bite, animal contact, slaughterhouse worker. They are also at high risk because of the infected blood of the tick or the tissues. Veterinary is high because of their procedure that they perform on animal. Healthcare worker, infected patient fluid, like in Pakistan, most of the healthcare during the outbreak, they were affected. Travel to endemic areas in outdoor activities. Okay, so knowing about the pathogenesis is very important because this virus cause multi-organ failure when after the tick bite, at the bite place or after contact with the blood, it start to first it encountered by the cells that it interacted macrophages cell. Later on, when it reach the lymphocyte, the lymph nodes, it's replicate. In case of viremia, generally there is a cytokine storm because release of interleukin 6, 10, which lead into the endothelial perforation of the lining because it damages the endothelium, which lead become very leaky. This which lead into hypotension, and there is later on chances of bleeding because of the low platelet. It can also damage the bone marrow, which result into low platelet. And the first stage there is low white blood cell because it directly affect the bone marrow. Later on there is high lymphocyte because in convulsive phase when the person start to recover. So in case of the kidney, there are chances of acute tubular necrosis because of the specific direct damage of the virus, sorry, or immune mediated it can be. In liver, mostly it affects the liver. In such cases, there is great chances of the liver failure. is called necrosis of the hepatocyte, specifically the mid zone of the liver. Okay, so here are some of the picture of the severely infected individuals we can see. Okay, case definition. Generally, there is a suspect case, probable and confirmed case. Regarding the suspect case, one with a fever, hemorrhage, and there is epidemiological link. And probable case, suspected case like fever, hemorrhage, and epidemiological link plus platelet less than 50,000 and white blood cell less than 3,000. Confirm case the one which is PCR or the IgM serum conversion is there. Here we can see in this the different phases of this whole infectious process that occur. Generally, the pre-hemorrhagic phase, which lies from 1 to 7 days, there is myalgia, fever, nausea, diarrhea. At that time, the PCR can be detectable. Then is the hemorrhagic phase, which lasts for 2 to 3 days with bleeding from various sites, hematemesis, melena, etc. Can be there. There is a convulsion, the recovery phase. In some of the cases, death can also occur. The case fatality is high. So incubation period generally, according to different mode of transmission, the incubation period varies. Like in case of the tick bite, it is 1 to 3 days. Blood transfusion is 5 to 6 days. Nosocomial is 1 to 13 days. It is because in case of the tick, there is high viremia. The most viremic, the lesser will, like the shorter will be the incubation period. Clinical feature generally like neck pain and stiffness, muscle and back pain, generalized body weakness, bleeding from any body openings, headache, vomiting, diarrhea, abdominal pain, sore eyes. There is sensitivity to light too. So there is this severe complication, disseminated intravascular coagulation, one of the complication, hepatic failure, renal failure, pulmonary failure, shock and cardiovascular collapse, CNS involvement like confusion, coma and seizures. Death typically occur during second week of life. Okay, so talking about the mortality, mostly it is because it occur in 5 to 14 days of illness. It's because of the multi-organ failure, mainly the liver. So hemorrhagic pneumonia can be there, one of the cause, cardiovascular disturbance, and mortality can be up to 40%, depending upon the immunity of the person, depending upon the healthcare facilities. Diagnostic is generally different. There are different modalities which can be used. One is the clinical examination. Then is the virus isolation and antigenic detection, polymerase chain reaction, serology. We will discuss one by one. So generally viral isolation is require BCL4, the Biosafety level 4 lab, due to it extreme risk. The cell line that is used is the Vero cell line taken from African green monkey. Limitation is time consuming, days to weeks, dangerous, high risk to lab worker, not suitable for routine diagnosis. Serology, IgM antibodies appear early. IgG indicate past infection or recovery. The limitation is that cross-reactivity possible with other viruses like we have discussed the Hazara, the Bunya, Viridae, or the other noroviruses. That is the other viruses that we have discussed in this group. Not useful in very early phase. So this why PCR is preferred. PCR most sensitive in acute phase. First 5 days it can be detectable, but still it also rely on the sensitivity of the assay that is used. Viral load decrease as the antibody develop. Advantage is high sensitivity specificity, confirmed diagnosis before seroconversion, useful in early outbreak detection. So this is the slide of the patient of the bone marrow. There is a hemophagocytosis of the blood cell, red blood cell, and the platelet. Okay, so this is generally the PCR test which are performed here at our lab. In this data from 2021 to 2025. In 2021, we performed 9 PCR in which there was no detection. In 2022, 165 in which 7 cases was positive. 2023, 60 we performed, then it was 2 positive. This year, we have performed 53 till this date, in which 8 was positive. So here you can see percentage was detected 7% and 93% were non-detected. Most of the cases are like from Mardan, Nowshera, Sawabi, Bannu, Lucky Marwat, Quetta, Chaman, Karachi. So as I have already mentioned that because of the most of people over there, their profession is like related to cattles, and the movement of the different tribes around the Pakistan border is one of the reason behind this. So treatment is generally supportive, fluid management, careful balance, avoid overload, electrolyte correction, oxygen therapy if mechanical ventilation is needed, blood product support, avoid IM injection because there is chances of bleeding. Instead, use acetaminophen, and unnecessary procedure should be avoided because of the ribavirin is one of the antiviral that is generally given and it's mostly effective in first days. Only antiviral with potential benefit and Crimean-Congo hemorrhagic fever most effective if given within first 5 days of illness, can be used for treatment in post-exposure prophylaxis. Route is oral or IV. IV is preferred in severe cases. Reduce mortality when started early. So here is the prevention protocols. Controlling animal movements, take control with acaricides on the animal like the permethrin. It can be different acaricide can be used for prevention of the tick bite, personal protection during slaughter, and proper waste management after slaughter, education of veterinary slaughterhouse worker. So, according to World Health Organization, there is some further regarding prevention. Avoid contact with infected CCHF patient and diseased. Wash hands regularly with soap and water. Encourage early treatment and CCHF treatment center. Use gloves and mask and practice hand hygiene with caring for suspected CCHF patient at home. Seek health advice. That's all for today. I thank you all.